All right, good morning, good afternoon from wherever you're joining us from. Thank you very much for joining this very exciting webinar that is focusing on the role of influencers in adolescent girls and young women's PrEP use. And we know that adolescent girls and young women have very complex lives, and they have important decisions to make, but they also do value the relationships that they have in their lives. And oftentimes when we do demand generation, we tend to focus more on the individual girls and women, and somehow tend to forget their support system. So today we really want to focus and look at some of the strategies that have been used before. What are some of the key lessons that we can learn from those interventions, best practices that we can carry forward even as we continue with the PrEP programming. So welcome once again, and continue to introduce yourself on the chat. I will go ahead and introduce amazing panelists that we have on board today. And it feels strange to introduce myself, but I'm Patricia Jekonaya, working with LVCT Health in Kenya. I'm the MOSAIC project lead. We have Susan Igras from the Institute of Reproductive Health, Georgetown University, and she has been working for about 30 years in international health and social development. Next. We have Polo Motswari. Polo Motswari is a communication professional who's been working for about 15 years in HIV education, radio, print media, community mobilization, and engagement. Ellen Mubanga from the Zimbabwean National AIDS Council, and she's been in this space for 20 years working on HIV prevention, and also working with the adolescents and young people to be able to access prevention services. Next. We have Nikita Shobalak from the WITS Reproductive Health Institute. Nikita is a project manager within the Implementation Science Department, and she has experience in marketing and graphic design, and her passion is in mobile health technology, public health communication, and community engagement. Mersini Beshaho is a youth advocate who advocates for sexual and reproductive health, and she's also a member of the MOSAIC Next Gen Squad representing Kenya. We have Havana Mtetwa. Havana works with Pangaea Zimbabwe AIDS Trust and is also representing Zimbabwe as a member of the MOSAIC Next Gen Squad, and you'll get to hear more about them. We have Zoe Mungai Baris working with MAN Global Health, and she's been working on public health and product markets and product marketing, and she leads program management and research on social behavior change programs in Africa and Central Asia. We have Donna Sherrod, also from MAN Global Health, and Donna brings on board 15 years of global health experience, working with adolescent reproductive health, family planning, and has also supported health product introduction, brand strategy, and social behavior change. Great, this is our agenda for the day. We will have presentations, and then to top it up, at the end of it, we will have another panel discussion with very interesting questions. Let's move to the next slide. Again, we'd really love to continue knowing you, so you can continue to register. I welcome Donna Sherrod to take us through building community acceptance for PrEP use among adolescent girls and young women in sub-Saharan Africa. You're welcome, Donna.
Great, thank you. Thank you, Patricia, and greetings to everyone. My name is Donna Sherrod, and as Patricia mentioned, I'm representing MAN Global Health, and I'm going to be co-facilitating with my colleague Zoe Mungai Baris. I'm going to first take us to set the tone for why we're talking about parents, partners, and peers, and introduce a summary of some of the work that was done over a year ago to get a better understanding of these supporters of PrEP use. Next slide, please. So I'm going to first talk a little bit about a review that was conducted. I'll explain just again quickly the purpose and methods of the review that was conducted about a year ago for MOSAIC. I'll talk briefly about the analytic frameworks that were used to define that review. And then I'm going to hand it over to Zoe, who's going to talk quickly about the highlights of the key findings. And just FYI, and we'll be sending a link on the end of, at the end of this, all of the details of this review are available to this entire group. Next slide, please. Okay, next slide. All right, so we, again, about a year ago, a review and expert consultation was conducted to help us kind of lay the groundwork for the understanding of MOSAIC's work, and specifically to better define what we mean by community acceptance. And a lot of things that happened since then, so we've been, as a collective, more clear about what we mean by community acceptance. And again, that had specifically designed or defined community acceptance for this work as support from parents, partners, and peers. And I'll talk a little bit about that briefly. But the review looked at 3 key questions, and it was a combination of a desk review and then also expert consultation that many of you were a part of. So the first question or set of questions was about what support do adolescent girls and young women want at each stage of their adoption journey for PrEP? I'll talk a little bit about the journey, the adoption journey, the kind of standard journey that we use to apply this. But that question, and then whose influence is most important as they move along those stages, again, helped us to land where we are with a focus on parents, partners, and peers. The second one was, as adolescent girls and young women move along this journey, and as they come to expect specific support roles from each of these individuals, the review sought to understand what are the factors that drive those influencers to support PrEP among adolescent girls and young women. And by factors, we mean sometimes often referred to as determinants, but attitudes, beliefs, knowledge. And we sought to understand what are those that are most key, or that the evidence has directed us to understand is most important. And then third, and some of these interventions are going to be discussed today, what are some of the promising interventions drawn both from HIV prevention, treatment, and care in the larger reproductive healthcare services space that have demonstrated success in influencing, again, or enabling these influencers to support adolescent girls and young women's adoption of reproductive health services, or specifically PrEP. Next slide, please. So as I already kind of introduced, our review focused on these 3 primary influencers. We also, and we all know this, it came out through the literature, obviously healthcare workers, and there's some others in the community that are also critical to influencing young folks' decision-making. But these 3 groups we deliberately decided to focus on because of their importance to the adolescent girls and young women themselves, and also because there was some complementary work being done specifically for healthcare workers. So parents, partners, and or caregivers, and female peers. Partners were defined as the boys and men who are the intimate partners of adolescent girls and young women. Parents and or caregivers, especially cohabiting mothers, were identified as critically important. And then the female peers, who are both either users or non-users of PrEP themselves. Okay, next slide. So, and as I mentioned, there were 2 parts to this review and consultation: a desk review that examined over, we looked at and then critically set up a selection criteria, but looked at over 468 peer-reviewed articles. Of them, 57 met the criteria, and we also looked through a number of project websites to gather program experience, gray literature, and other write-ups and toolkits to understand and get a better view of what's known. And then many of you probably remember, it is literally a year ago, I think almost a year ago, where we held an action tank. MOSAIC held an action tank, convened many of you, implementers, ministries of health, young people, to review the evidence, capture programmatic learnings, hear from projects that have evidence, and talk through what's worked and what were some of the challenges, to identify specific opportunities for our own intervention and adaptation, and to make recommendations and guidance moving forward. Next slide, please. Okay, so just real quickly, wanted to just introduce the analytic frameworks that were used to kind of structure the review. The next slide. Okay, so the first one I mentioned is the PrEP user journey. So I think many of you are familiar with a typical user journey. This framework is often applied to the adoption of products or services globally. And these 6 stages typically define a process of becoming aware of a new product or service to continued use. And here we depicted discontinuation and then restart, as is often defined by, or often steps that define adoption of PrEP and other sexual and reproductive health services. So we use this 6-step process to define first what are the types of support that adolescent girls and young women want as they move through this stage, and who do they want support from as they move through each one of these stages. So when Zoe gets into some of the factors, you'll see that we've defined those factors along each step of this journey, because this was critical and came out through much of the literature. And next slide. And then the last one, and you can just kind of click through this, it's a bit animated, is the theoretical domains framework. So for those of you who may not be familiar with this, the theoretical domains framework is kind of a next step past COM, capability, opportunity, and motivation, which is a widely used framework to help us understand the drivers of human behavior. And essentially the structure is that there are certain skills and knowledge elements, that there are social and physical elements that influence individual behavior, and then there are motivation elements that influence behavior. The theoretical domains framework takes those COM buckets and goes a little bit further to define them more clearly. And so we use this because it helped us kind of dig down into each one of those specific factors and understand even further what the literature was telling us. And again, as Zoe goes into her piece, she's going to be talking about the factors through this lens. Okay, so that's the tee up. Over to Zoe, who's going to take us through some of the specific findings of the review.
Thanks, Donna. All right, we're going to jump into understanding community influence on AGYW's PrEP behaviors. Next slide. All right, so we'll be looking at how AGYW desire for their partners, parents, and/or caregivers and peers to support them throughout their PrEP user journeys, and also the behavioral drivers of these key influencers. Next slide, please. So male partners in the PrEP user journey for AGYW, male partners came up most frequently in the literature we looked at as influencing PrEP decision-making. Fear of disrupting this relationship with male partners can inhibit PrEP uptake for AGYW, but supportive male partners can play a critical role in facilitating PrEP use. So below, as Donna mentioned, we have the different stages of the PrEP user journey for AGYW. And during each of the stages, we've listed the different ways that they prefer for their male partners to show up for them and support them during those phases. So in the awareness phase, AGYW are seeking open dialogue with their partners in support of PrEP use. They're in the uptake and evaluation phase. Similarly, they're looking for open communication and also active support of use and financial support when needed. In the early use phase, they're looking for emotional support, adherence support, and this can include pill reminders, again, open communication. In the persistence phase, they're looking for similar things as the early use phase, but additionally financial support. And then in the discontinuation phase, they're looking for support with method switching if needed. Next slide, please. So these are some facilitators of and barriers to male partner support of PrEP use for AGYW, and these are organized by the theoretical domains framework that Donna spoke to earlier. So some facilitators of male partner support include correct knowledge and awareness of contraceptive methods and HIV prevention from credible sources such as consultations with clinicians or IEC materials. If male partners have effective communication skills, they may be more eager to participate in these sometimes difficult conversations with their AGYW partners. If male partners come from a community that's already supportive of healthy HIV prevention behaviors, they're more likely to be supportive. If male partners have acceptance of women's decision-making power and agency, and if they have positive beliefs about the consequences of AGYWs using reproductive healthcare products. For example, if they believe that those products will bring more health to the relationship or bring them closer. So some barriers to male partner support for PrEP use include incorrect knowledge of sexual health information, a lack of effective communication skills, restrictive gender norms, and also negative beliefs about the consequences of AGYWs using use of reproductive healthcare products, such as that it may promote promiscuity, which is a common misconception, and then male emotions, including beliefs that partners may have about infidelity and relationship distrust that could discourage PrEP support. Next slide, please. All right, now let's dive into parents and caregivers and their role on the PrEP user journey for AGYW. Parents have a strong influence overall on adolescent health behaviors, but often AGYW do not seek reproductive health information from their parents because they don't want their parents to know that they're sexually active, and they fear being considered promiscuous from their by their parents. So again, we have the different phases of the PrEP user journey below. And during the uptake and evaluation phase, AGYW would like vocalized approval from their parents for using PrEP, consent or permission from their parents, and referrals to PrEP-related services. They're looking for similar support in the early use phase. In the persistence phase, they're looking for active support and adherence, such as reminders to take PrEP and also storage support. They'd like open communication around PrEP use again, and then they're seeking financial support by offering transport or money for services from the parents. In the discontinuation phase, they're also looking for support method switching if need be. Next slide, please. So here are some facilitators and barriers of parental support for AGYW PrEP use. And again, this is organized by the TDF framework. So some facilitators of parental support include correct knowledge and awareness of HIV prevention and reproductive health care, effective communication skills, and an open relationship with their AGYW. If, again, they come from a community that already supports healthy HIV prevention behaviors. And when parents have goals for a great future for their children, they may want them to remain HIV negative to achieve that future. And then some barriers to parental support for AGYW PrEP use include incorrect knowledge of sexual health information, a lack of strong communication skills, social taboos surrounding discussing sexual health with parents. What did come up are some taboos between fathers having these types of conversations with their daughters about sex, a lack of parental role models themselves for having open conversations about sexual health. Stigma and gender norms may limit parental acceptance, especially the belief that AGYW should not be sexually active before marriage, and then environmental influences, including a lack of physical proximity to AGYW to facilitate such a discussion. Next slide, please. All right, and lastly, we're looking at peers in the PrEP user journey. So peers, which are usually same-sex friends or same-generation relatives, are a primary source of reproductive healthcare information for AGYW. And AGYW in the awareness phase are looking for shared information from peers. This can be specifically information about their experience with PrEP or also their sexual health experiences. And furthermore, other general related health information. And they also look to their peers often to be advocates for PrEP, not only in their interpersonal circles, but also they like when their peers are advocates in the wider community. They're looking for similar support from their peers in the uptake and evaluation phase. And then in the early use phase, they're seeking, again, shared information, support from their peers to facilitate disclosure to their parents or partners of their PrEP use. And then again, tying in this advocacy element, they'd like their peers to facilitate PrEP delivery at the community level. In the persistence phase, they're seeking support with adherence, including via support groups and also by their peers modeling similar PrEP-related behaviors. They're looking for advice, tips, and PrEP-related referrals from their peers. They're, again, looking for support, facilitating disclosure, and also they're looking for their peers to be advocates on the community level if possible. And then in the discontinuation phase, they'd like reminders from their peers to take PrEP. Next slide, please. All right, here are some facilitators and barriers to peer support for PrEP. So some facilitators include correct knowledge and awareness of contraceptive methods and HIV prevention, effective communication skills. Again, if peers come from a community that already supports healthy HIV prevention behaviors, when peers have positive beliefs about the consequences of AGYW's use of PrEP, and then also if peers themselves feel empowered to make their own reproductive healthcare decisions, they'll be more supportive of other AGYW using PrEP. And if they have personal experience, such as recent HIV infection or PrEP experience, they're more likely to be supportive. Some barriers to peer support for PrEP use among AGYW includes incorrect knowledge about oral PrEP, stigma around PrEP use, limited time and financial resources may inhibit them from giving the time and attention and support they can to other AGYW, and also difficulties with accessing PrEP. Furthermore, what might inhibit their support for PrEP includes negative beliefs about consequences of PrEP use for AGYW, and when they focus on risk or responsibility to motivate PrEP use amongst other versus a more positive outlook, such as relationships and fulfilling future desires. Next slide, please. All right. So to access the full report and also an inventory of interventions, Donna mentioned earlier that as a part of this work, we also collected a series of interventions and made a list that went through effective community acceptance interventions for the HIV field, but also adjacent sectors. And so for a list of that interventions inventory, a full report, and sources, you can visit prepwatch.org, and we have the list. The link listed here. Thank you everyone for being here, and we'd like to open it up to a brief Q&A.
Thank you very much for the great presentation. I will request for any questions or comments, please keep writing them on the chat, and I'll welcome the next presenter. We'll read out the questions as they come in. Nikita, over to you.
Thank you. Hello, everyone. My name is Nikita Shubalak, and I am part of the implementation science team at WITS RHI, Johannesburg, South Africa. I'm excited to share with you how Project PrEP has engaged parents to support adolescent girls and young women on their oral PrEP journey. Next, please. Okay, so as we may know, oh, has it moved? Yes, so as we may know, adolescent girls and young women face barriers with access and uptake of oral PrEP and other SRH services. This is where social mobilization for community entry, specifically ongoing engagement with key influencers, could overcome some of the barriers that AGYW face. So Project PrEP aims to improve the understanding of uptake and continuation of PrEP among adolescent girls and young women and vulnerable groups in real-world settings, and inform delivery models for service integration into comprehensive sexual and reproductive health services. The goal is to meaningfully engage parents or caregivers of AGYW to encourage support and approval of their daughters' health-seeking behaviors, specifically HIV prevention services. And we also want to equip parents or caregivers on how to support the AGYW in the continued use of oral PrEP. I just want to mention that Project PrEP is funded by UnitAid and implemented through WITS RHI in close collaboration with the National Department of Health. In Tshwane specifically, we partnered with a CBO called the Northern Hope Foundation. Next, please. So let's take a look at the Project PrEP's intervention approach. Here we can see the ATA model, that was conceptualized by Project PrEP and used for the intervention approach. The model is underscored by meaningful youth engagement, credibility, trust, and a holistic approach that places communities at the center of it all. So firstly, we can educate or create awareness. And this is where young women can say, this is something new. What is it? Then there is an interest or desire, and she can say, this is interesting. I think I want to know more. Next, she wants to try it, and eventually she would say, yes, this is something I can do. Next, please. So I'm presenting 3 interventions that took the form of parent or caregiver dialogues, mother or grandmother dialogue prayer days, and a social media campaign. Here you can see the parent dialogues which took place outdoors in an intimate, smaller space, and as well as the mother and grandmother prayer days where women are dressed in church attire attending the prayer days. You can also see images showing different types of messaging and imagery that we used on social media. Next, please. So let's get to understand exactly how the intervention with Tshwane parents and caregivers took place. So we did the parent and caregiver dialogues and the mother and grandmother prayer days. Looking at the second column of how we carried out these activities, the parent and caregivers of AGYW residing around healthcare facilities or mobile clinics in Tshwane were mobilized by community-based organizations to attend. These small events were supported by radio campaign, printed materials, and social media that are targeted to AGYW men and women. The scripts that we developed for both of these events were developed by programmers and site level staff and adapted based on feedback received from the CBO. And all staff as well as the CBO were trained on oral PrEP and community sensitization. It is important for us to provide knowledge. So we highlight the rising number of AGYW HIV infections and unintended pregnancy and the potential reasons. And then we focus on the opportunity for parents to be agents of change in their children's lives. This was incorporated with prayer for HIV prevention and those infected and affected by HIV. We also discussed the importance of supporting AGYW when it comes to accessing SRH services, including PrEP, to reduce the high incidence in the community for that cohort. And we request support from these parents to encourage their daughters in service uptake. The duration of the parent dialogues is ongoing, and Project PrEP aims to have at least 2 parent dialogues per quarter in all implementing clusters. And the prayer days or other special events happen when there are major obstacles to initiation or continuation of PrEP. And that's when we strategically design these events to address those obstacles. In terms of the format, both of these activities took place in comfortable community spaces, and all catering is provided by the CBO. Next, please. Okay, looking at social media, these posts were inspired by these parent or caregiver engagements and developed by head office staff. We shared about 12 posts on the MyPrep South Africa's Facebook page for about a month. Half of these posts were boosted for a 1-week period among male and females aged between 30 to 65 years in all clusters. And the messages used on the post are basically to encourage parents to talk about PrEP and empower them to teach young women how to prevent HIV. We also had a call to action on these posts, and that directs people to either chat to us on Facebook Messenger or to visit our website for more information. As you can see here, the posts were designed with graphics, and the headings are either in English or vernacular. Next, please. Okay, looking at our monitoring and evaluation for these events or interventions, these were done through registers, and attendance is captured and verified through photos or videos. We also capture the emerging themes, ideas, the concerns, or the frequently asked questions so that we can address potential gaps. For social media, we use Facebook Analytics to gather insights. The mother prayer days, we had 3 of them, and they reached up to 100 parents. And here the parents or caregivers were able to make a connection between empowered AGYW and religious beliefs. I would like to highlight a quote from one of the mothers of an AGYW who attended a Sunday dialogue. Open quote, "When I was young, no one spoke of these things, but now we know, and our daughters don't have to make the same mistakes, and they don't have to live with what we had to live with," end quote. The parent and caregiver dialogues were also supported by radio campaigns, printed materials, and social media, as I've said before. And from these dialogues, we had 447 parents that were reached in these more intimate, smaller spaces. In some instances, parents are hesitant or were hesitant to engage deeply in a group setting, but we found that after the dialogues, when we have tea time, it is a vital time to create further engagement opportunities. On Facebook, our post reached, each post reached an average of 1,600 people, and we get about 88 engagements during a 1-month period. And all of these approaches will continue and will be formally evaluated going forward through surveys, focus group discussions, and in-depth interviews. Last slide, please. So we have seen how meaningful engagement with parents or caregivers of AGYW can overcome barriers that AGYW experience, and we can push this forward by including the following points in our interventions. It is important for parents or caregivers to have an ongoing holistic engagement and skill-building workshops on how to support their daughters' health-seeking behaviors. Our engagement strategies need to be varied in format to ensure they are appealing to a wide range of people. The idea of social media campaigns should be to invite parents to join on an online conversation, and this gives them the opportunity to talk to experts and leaders in the community. Social media campaigns should also feature testimonials of parents who have supported their daughters to either try or continue on PrEP. And other offline activities such as mural paintings, dialogues, or other small events should advocate for an end to HIV stigma and normalize HIV prevention among AGYW and the communities they live in. Before I end, I'm glad to share that a paper has just been written by lead author Elmarie Bredenhan, and it describes the demand creation strategy as implemented by Project PrEP. And the strategy was informed by the ATA model, an adaptation of the ADA and innovation adoption model, which I mentioned earlier. And the paper goes on to prove how this model supported the successful uptake of HIV prevention services and how it can be used to roll out other biomedical prevention products and be adapted by other low to middle income countries. That is all from me. Thank you for the opportunity.
Right, thank you very much, Nicole, for that great presentation. We have 1 minute for you to respond to just one question. Did you document questions or concerns raised by mothers, grandmothers, and do we have materials developed to address some of the frequently asked questions?
So these questions or concerns are captured at each event. I don't have them on hand, but we definitely do include them in our reports. And we do address these kind of comments or questions when we are at the dialogue. I think the script that we develop tries to also address these kind of things. But yes, definitely something that we need to maybe develop a list or a document of all these kinds of frequently asked questions.
All right, thank you. And one last question. Do you see any uptake of PrEP amongst the mothers of the girls? Or do you offer services to assess their HIV risk?
So our services, although it's for AGYW, we do provide it to anyone who wants it. So if a mother does decide on that day after the engagement that she wants to access, she is more than welcome to. So yes.
Great, thank you. We will move on to the next presentation because of time, but we take note of your questions. Nicole, if you can just go to the chat maybe and respond to some of the questions that I haven't read out. I want to welcome Susan Igras. Over to you.
Thank you. I am delighted to be here. I'm talking about something that isn't PrEP, but has some interesting implications for PrEP, and it's the husband schools. Next slide, please. So it's an intervention that works with men to improve women's use of reproductive health services in Niger. And that may seem, might raise a question, but I'll explain how it actually works in this presentation and implications for PrEP. Next slide, please. So husband schools were, they have some important lessons for the MOSAIC project, right? They started in one region in Niger and now are scattered around the country in thousands of husband schools and thousands of communities. And currently they're linking husband schools to two other efforts, the Safe Spaces for Adolescent Girls and Future Husbands Clubs for adolescent boys. And I'll talk more about that later to explain. Next slide. So the big problem with women's use of reproductive health services, so that's antenatal care, delivery, family planning, postpartum care, an analysis was done by UNFPA, and it really showed it was men who were stopping women from using the services for a bunch of reasons. A lot of it is cultural practice, but a lot of it was mistrust of health services, of men-women dynamics where men are the deciders in everything in a woman's life. And so, next slide. UNICEF and the NGO Songe developed this intervention to really try and get at how do you get men who are kind of anti a lot of this reproductive health services, women's ability to choose. How do you work with them so that they themselves become social change agents, which is what the husband schools are about. So after they're trained, you see different, these are just community men. They're not schools in the formal sense, but model husbands are trained as citizens and sort of this flat leadership structure where they all have roles to play, but also in reproductive health and male engagement, very simple because it's a community-based intervention. And then they go out and sensitize and do one-on-one outreach. So they might, they have a flip book and it has just some very simple images of women and men together organizing around a reproductive health, whether it's, walking to the service delivery site or things like that. And they will use that flip book and talk with the community and other men during baptisms or weddings, or sometimes one-on-one visits when the husbands that they're trying to convince, who's like, I'm not going to let my wife go. And they'll try and convince them one-on-one. And there's also an important service linkage to these schools, that the school members coordinate with the head of the health service, the community health post or center, to work together on reproductive health. So it legitimizes in both groups' eyes the role that men can play in the community. Next slide. The theory of change, it helps explain how men on the left, and their activities can lead to increased use of services by women. So I was with the Passages Project, which has ended in September, but it was looking at social norms change. So we worked with them with stakeholders to create this theory of change, and we added normative environment, which wasn't there. They were just focused on individual changes. But if you look in the circles in the middle, you can see how the activities of men could start leading to this shift in the way community sees the situation and what they can do about it to get women involved. And so it's really a norm shift this project was working on, or this intervention. Next one. So the study I'm going to share is a qualitative study, but yeah, we got invited after UNFPA and SOJ did a smaller impact evaluation study that showed similar statistics that, like you see here, that where husband schools were in the community, you could see that by 2012, there's a lot more use of reproductive health services than in 2006 before the husband schools existed. So that's sort of regional district level data, but there was an evaluation in 2014 commissioned by UNFP that showed similar statistics that showing that, yeah, there's some contributory effect here. They're having an impact. So next slide. So that led to this study on how it actually works, like looking inside that theory of change. Do those things actually happen the way the stakeholders said they did? So we were looking at gender dynamics, because there was fears that maybe men were becoming even more dominating than they were because they became model husbands. But the other question too and it's a social change question, is how do these new ideas diffuse to the broader community, and how do they affect how people see their roles in ensuring good reproductive health? Next slide. So I'm going to share just some top line studies, and you can actually access it on the Passages Georgetown website, the actual study, which gives the background I just described as well as the findings of the current study. But the key finding is that when you look at that social ecological model, community and health systems, partners, family, and peers, there was actually a shift in the normative environment that became more supportive for women using reproductive health services, which is represented by the individual, right? It was those shifts in support for women using services that really happened, that allowed them to support and sustain that individual behavior change. Next slide. So what supports these changes? So the study tried to understand, again, we were looking and testing how the theory of change worked in reality. So what if you dig down, what's going on social change and gender-wise? Next slide. So part of it was acceptability, that the communities valued the contribution of these 100 husband schools. So there, we were asking before and after, right now every community we went to had a lot of admiration. Men wanted to become model husbands. They were seen as so change agents in the communities, whereas before they weren't trusted, they were rejected. People were saying, how can a man get involved in reproductive health? So there was a significant change in their acceptability as change agents. Next slide. Also, the importance of RH services, that men became supportive of that, which was, the main aim of this intervention. That husband schools today are, men admire and accept husband schools, whereas before there was they didn't think that men had roles in providing information. There's a lot of prejudice and taboos about how men should be engaged in women's reproductive health, and it was their only job to be a gatekeeper, which had shifted everywhere. Not just for men, actually for women also. And that's what this next slide is about. Next slide, please. So the second question that we were asking, so there's a shift in the gender dynamic that became more fluid and more accepting of different people, men and women playing different roles, but how did that actually percolate to the community? So it was very clear then, especially in a society like Niger, where women often aren't allowed to talk to men unless they're in their immediate household, right? Because of just the way the society is structured. If you think of the model husbands as those people in blue in this social network map, they were reaching out to their male friends. And that was then creating a whole network influence on men in the community, but they're also talking with their wives. And so their wives took it on because they were really interested and excited about this information and started sharing it through their network. So it was that combination of men and women talking and discussing these new ideas on reproductive health that led to the change that we are seeing, so that it could actually support a social change effect. Next slide. So there were visible changes in the gender dynamics, that the relations between men and women shifted, that there was more power sharing, there was greater communication at the couple level, but also at the community level, because there's a lot more discussion on reproductive health and women using services. Men were more supportive to their wives, and there was just more trust in each other and in the services. So those were pretty significant changes for such a simple intervention. But culturally, the man still is the final decisionator. So it's just that different spaces opened up that didn't exist before, which in this community, in the society of Niger, was pretty important. Next slide. So just a couple of thoughts on how it actually worked then, when you think of it as a program, what supports the conditions for success. In 2016, the Passages Project did a scoping review looking at HIV, WASH, reproductive health, primary healthcare, community-based programs that had social change effects, and found that these were kind of 9 characteristics that allowed them to work at that social change level. And husband schools had all of these norm shifting attributes, right? So that seeks community level change, engages people at different levels, corrects misperceptions about harmful behaviors, confronts power imbalances, creates safe spaces for reflection, roots the issue within the community's own value systems, accurately assesses norms, uses organized diffusion, and creates positive new norms. So husband schools had all of these. Next slide. And this is a really busy slide, but the point is along the scale-up process. So you see at the left in 2006, it was just an idea that was being beta tested, the husband school approach. And by currently, they're in every single region in Niger and actually in West Africa. But if you look at the yellow bursts, right? So part of it was piloting and adjusting, but then guidance was developed so that others could use this approach. That there's a lot of sharing experiences to build support among NGOs that were implementing and ministry partners that were working with them. There was evaluation and evidence that showed that it worked. Next slide. So those are important things to keep in mind if you're thinking of scale up. And then looking also at sustainability. The communities, they see model husbands as valued agents of change, part of the social tissue at this point, right? But there's some buts. As the number of schools grows, so does the cost. So, how do you manage this simple intervention, which is simple, but when you multiply it by thousands, it becomes a lot more expensive. How do you support it technically to make sure that it's being implemented as planned with the support of the local health centers? And probably the biggest issue was that it's really not integrated yet into the Ministry of Health and Social Affairs plans and budgets. It's really an NGO effort that's donor supported. Okay, next slide. So just the final one on testing. So the way we think about these social change interventions, there's always going to be new adaptations to the husband schools, right? And so so UNFPA and SOJ have been applying it to other social and traditional practices like female genital cutting. They're now trying it out in urban contexts, but it's the last one that I think is probably most relevant to PrEP. They're now trying to create at every community 3 interventions that are mutually supportive, right? So girls, safe spaces. So that's for unmarried young girls. Future husbands clubs, which are unmarried young men, are having their own intervention, working in parallel with husband schools, which are basically older men. And as we were saying earlier, that also reach moms. So it's moms and dads. And that's the new approach. And I haven't seen the study. They're doing a study to look at when you put those 3 interventions together, does it really create these synergies that leads to a lot more shifting of social norms around women's use of reproductive health in the future and currently. So I think that's it. Next, I think that's it, right? Oh, okay. So this is the last slide that, husband schools emphasize community and individual sensitization. So they're not so much into knowledge, attitudes, that kind of information. They're really, how do you change the social space at a community level to support women use of reproductive health services? And they're being offered in parallel can allow you to reach different influencers of young women, men, and couples, but it also broadens this norm shifting effects, right? That it can deepen and broaden the community expectations of what is good PrEP and other preventive behaviors. That's the last slide. Thank you.
Thank you very much, Susan. We are still following the chat. I haven't seen any questions specific for you. And so we will move to the next presenters, Mercy and Havana. Over to you, the Next Gen Squad.
Hi, everyone. We'll be presenting to you about HIV prevention ambassadors. I'm waiting for slides to come up. So this presentation is going to be made by myself, Mercy Bishaho, together with Havana Mtetwa, and we're going to present to you about a peer-led intervention. Next slide, please. So the intervention overview is that the HIV prevention ambassador training for adolescent girls and young women prepares young people to become ambassadors who share information, support their communities in the uptake of PrEP through interactive activities, discussions, and action planning. So some of the organizations that have put this document together, there is LVCT Health from Kenya, VITS RHI from South Africa, PISA from Zimbabwe, AVAC, Collective Action, FHI 360, Uganda, US, and Zimbabwe. So this manual has information about tips of using oral PrEP, the ring, and Kabile. Next slide, please. What we have available now, there's the first edition that focused on oral PrEP, but we have some new releases coming in. One on training for adolescent girls and young women, the 3rd edition, which will focus on oral PrEP, the PrEP ring, and PrEP, and it will be relevant for cisgender adolescent girls and young women, with modifications to include trans adolescent girls and young women. There's also another one for coming next year for oral PrEP, ring, and also Kabile, but for the trans people. Next slide, please. So who is an ambassador? So an ambassador will typically be a person between 15 to 24 years who identifies as a female and is based in East and Southern Africa. Typically, they would have responsibilities like going to school, they either have a job or works in the community that they're being enrolled from, and they would have some sort of training as an ambassador. And some of the activities that they would do include one-on-one support, group education and sensitization, and accompaniments for PrEP services. As ambassadors, the support they get includes support for organizations to provide ambassadors like check-ins, there's connection to referral organizations, a recognition of their work, and some logistical support. Next slide, please. As what this training package includes, these facilitator instructions, which include how to use the manual, selecting and supporting ambassadors, tips for tailoring and conducting the training with your participants. So for example, here we have reading the manual before you go training. How you can create a participatory environment with your participants, how to be able to create a safe space for the participants to make them feel comfortable, and also being able to reflect on your own values and attitudes and beliefs and how they may affect your work. Next slide. There's also part of the training session. So this is just an example of what you might find in the manual. You will find in the manual. So there is foundational knowledge on human rights, getting to know your body, HIV and AIDS, gender inequalities and violence, and being able to respond to disclosures of violence. There's also information on PrEP methods that includes finding out about PrEP, deciding to use PrEP, getting PrEP methods, and being able to tell others, amongst other topics. And then also support for ambassador skills to be able to know as a peer support skills, what would I need to do? How do I set boundaries? What, after all this, how do I take care of myself? Next slide. The toolkit also has other toolkits within it. So there's a collection of resources and worksheets for ambassadors to use while working in the community. So there is a PrEP, PEP, and ART tool. There's the HIV transmission and HIV prevention toolkit. And there's also the PrEP journey map tool that has all the three methods together. There's the oral PrEP, the ring PrEP, and the hub PrEP. So there's a journey tool that helps the participants to be able to keep a track of themselves, also like decide what method would work best for them. If they need to choose a method that will help them remember when to take the medication, which one would work best for them. So this journey map helps them to do that. And there's also like the gender inequality problem tree, being able to identify the drivers of gender-based violence within the community. Next slide. So I'm going to be sharing just a bit of experience on how this is conducted. We have within your community, you select about 20 participants. You will be able to make sure that you have scattered them, not selecting them from just one area, so that you are able to diversify and make sure that knowledge is spread around. So we also select people who are identified as female. So it doesn't necessarily have to be that you are assigned female at birth. Provided you identify as female, you qualify to be trained as an ambassador. The training takes about 3 to 5 days, and you go through the whole manual as from what I have presented. And eventually at the end of it, everyone gets a toolkit so that you can be able to refer just in case you didn't get everything. And they graduate to become ambassadors. And so from then on, you get to be supporting them. But eventually, when with the manual, they're able to refer themselves back to it. And going forward, I'm going to hand you over to Havana. Havana, take it over.
Good day, everyone. My name is Havana Mtito. I'll be taking you through the impacts that the trainings have had, the HPAT trainings have had in various countries in Africa. Next slide, please. So when we look at the progression of the ambassador HPAT training, we can see that it's been done in Zimbabwe, and South Africa, and Kenya, with a total of about 8 trainings that were conducted. In Zimbabwe, we have 2 trainings that were conducted with 37 ambassadors that were trained. In South Africa, 5 with 107 ambassadors trained. And in Kenya, we have 1 training with 30 ambassadors trained. So here we can see that after the trainings, ambassadors have held PrEP talks at universities. They have organized PrEP HIV prevention walks on World AIDS Day, and they've already contributed to a number of really interesting social and HIV-related impact. So here we can see that in the 3 countries that were piloting the training from 2019 to early 2020, the pre and post tests have shown an improvement in knowledge attitudes. Next slide, please. So in Zimbabwe, full testing was done with the ambassador training manual. This included a rapid non-research field test that was conducted with 17 participants in MOSAIC, Zimbabwe, to collect knowledge change and qualitative input from ambassadors, as well as PrEP uptake data. The pre and post test responses showed an approximate 24% improvement in oral PrEP knowledge amongst ambassadors. It's worth noting that these range from a variety of ages from 20 to 40 plus, with a total of 17 ambassadors in total. However, the information about their sexual orientation and sex assigned at birth wasn't collected. Next slide, please. Here we can see that the adolescent girls and young women oral PrEP uptake increased by 59% at the original facilities. After the training, the trained ambassadors also supported the initiation of PrEP service delivery at 10 new facilities. And new ambassadors were trained in 2020 to cover the new facilities in the district. It's really interesting to see how the HPAT has contributed to not just the uptake of ambassadors, but we will see within the next slides that they've also contributed to the continuation of PrEP, which is something that we have struggled with. That getting them onto PrEP hasn't been the biggest issue. Helping them maintain the uptake of PrEP has been what we've been worried about. And that's really interesting to see how peers influence the use of PrEP amongst adolescent girls and young women. Next slide, please. So here from the MOSAIC ambassadors, we can see that the qualitative discussions were carried out with ambassadors 6 weeks and 4 months following the training. Their knowledge gain increased their confidence and helped expand the number of adolescent girls that were able to connect with and refer to oral PrEP initiation. They were also able to maintain contact with them in order to facilitate continuation. And interesting enough, the ambassadors reinstated that using their new knowledge on oral PrEP helps them support the AGYW, which is exactly what we wanted to see, and that's amazing. If you look at the quotations on the right side of the page, we can see that a male ambassador says, when I give them the book and flyers to read, they actually come back and we go to the clinic together. We can see such an interesting dynamic. This is a male ambassador who's saying that these adolescent girls and young women are comfortable going to him and going with him to the clinic so that they can get PrEP with him at the same time. A female ambassador says sometimes during the literacy sessions, the clients will think I'm sharing my own opinion or what I think about PrEP, but then I'll refer them to the facts in the book and help them understand and believe what I have taught them. This is interesting because we want to make sure that everyone knows that the knowledge that we impart on them is impartial and not subject to the bias of the ambassador themselves, which has really increased the confidence that they have in the ambassadors and the ability that they have to take up PrEP and continue with PrEP. Next slide, please. For further information, I think Shaila is going to put in a link to a blog that helps to co-author so that you can read more about exactly what we've done in MOSAIC with the HPAT trainings and the HPAT manual itself. Thank you so much for listening. And if you have any questions, I'll direct you to the Q&A, or you can type them in the chat box for me and Mercy to answer. Once again, thank you very much.
Thank you very much, Havana and Mercy. So we have a few minutes for questions. If you have any question, you can quickly raise your hand, or you can also type it in the chat. We will read it out. And thank you for all the great comments that are coming up about how innovative this session is today. There's a question, Mercy, were ambassadors also on PrEP? The ambassadors who were trained, were they on PrEP?
Some of them had previously been on PrEP, yes.
And some of them were on PrEP.
Yes, Pat. But it's not a requirement for you to be an ambassador. You don't have to be on PrEP, but it's okay if you have been previously, or if you are still on PrEP, you can be an ambassador.
Yeah, sure. Thank you. I can see a question for Sarah. Is the husband project going to be replicated in other African countries? Do you want to take that?
Yes, it's actually spread throughout. I think it's in like 10 countries now in West Africa. I haven't heard of it being tried yet, adapted for East or Southern Africa. But again, it's all around issues of reproductive health, and then some new variations on female genital cutting. And it's through the World Bank SWED project, which reaches regionally. So that's how that was kind of the financing for it. And it's been well received.
Great. Thank you. Thank you very much. So one last question, I think, for the ambassadors. Let me just get to it. Are ambassadors health professionals? This is because it was mentioned that their toolkit has ART, PEP, and PrEP. Are they health professionals? Havana, do you want to take that? Or Mercy?
They are not health professionals. They are PrEP ambassadors. The toolkit has guidance on what ART is, what PEP is, and what PrEP is, but it has not made them health professionals. They are not doctors, they are not counselors, they are peer supporters.
Yeah, thank you for that. So the ambassadors don't really have to be health professionals, but of course, some of them are taking up training in the health field. Yeah, but there's, so the toolkit also has like the requirements of how to select an ambassador, which is quite informative. When you have time, you can look through that. So one last question, how can we get technical assistance to train our ambassadors? This is from Liberia. So we will put on the chat an email where you can write to and request for technical support to roll out the training. Casey will put it up. Great. So we want to move on to the last part of this session today. And this is a panel discussion that will be talking about adapting interventions to reach influencers. And our panelist for this session is Polo Motswari from Japaigo and Ellen Mubanga. Welcome, welcome. And I will move on quickly to our first question to the panelists. Which influencer population has your country prioritized in your current demand generation activities, and why?
Thank you for the opportunity. If I may start, my name is Polo Motswari from Lesotho. So what we have prioritized, the population that we have prioritized, maybe to specifically talk about parents, because what we have seen is that in a country of ours with a lot of, many people on HIV, okay, highest prevalence amongst adolescent girls and young women, we felt like maybe to encompass or bring together everyone so that they're able to support our adolescent girls and young women. And this through the information, this is what we get from LIFIA, and our LIFIA is the Lesotho Population-Based HIV Impact Assessments and other surveys that have been done. So we felt like because they are adolescent girls, they are 15 years and above, most of them are still with their parents, and they need approval sometimes to do other things. And what we have seen also is, as most of the speakers today have said, adherence, there is not much of a problem for young people to come and maybe get their first initiation into PrEP, but adherence is a big challenge. So when we talk to them, we found that they are scared of their parents, they have to hide them their PrEP, they are not very free, so sometimes they forget, and then they eventually stop using PrEP. So we felt like maybe to bring parents together so that they understand why young people want to use PrEP would be very, very important. But also maybe to finish by saying that we wanted also the community, the acceptance for the community generally, so that they understand that PrEP is just another choice of prevention, is just an additional choice that young people can use so that they are able to support them. So just to summarize, those are the main reasons why we wanted to prioritize on parents. Thank you.
Thank you very much. So Lesotho is prioritizing parents, and there is evidence for why they're doing that. Ellen Mubanga, tell us the Zambia story.
Thank you. So the Zambia story is similar to Lesotho in that for us, we are also prioritizing parents. And this has been done that we have held a number of dialogue sessions that have involved the parents as well. But we have gone further. We have not just said the community, but we are also engaging faith leaders. And this is because we have realized that faith leaders have a significant influence over the adolescents and young people. And we have said we need to bring them on board. So we have held activation sessions in Zambia with the young people, with parents, and with faith leaders, as well as other key influencers, such as civic leaders. This is because in terms of our setup, most young people tend to have the influence of these key populations, the parents, the faith leaders, and the key civic leaders where they are found. So we have, as a country, prioritized these as influencers over the adolescents. And also it stems to the fact that our current HIV prevalence is also high among the adolescents. We have just released our results for the Zambia, and we are having new infections, the annual infections still standing at 28,000 annually. And when you look at this breakdown, we find that the young people are the ones who are mostly affected. And the prevalence also in young people, as the ages between 20 to 24, you find that it increases in the girls, and it increases as the age also advances. So we know that during 15 to 24 years, the influence comes from the parents, the influence comes from their faith, the influence comes from the political scenario, the civic leadership around them. Thank you.
Thank you very much, Ellen. So for highlighting the priorities for Zambia as parents and also the faith leaders. So to the next question, please describe how you have approached efforts to address these influencer groups. So you said there are some activities that have been done. If you could just describe some of those approaches that have worked with the influencers that you have highlighted.
Maybe I'll go first here. So that I just highlight. So what have we done to approach them? One of the channels we have used is to create dialogues between parents and adolescents, but also as
Hi, Ellen, can you?
Our implementing partners go out
Hello,
Hello?
we lost you for like a minute.
Oh, okay.
But
So
you
what
can
I
continue.
said is that, yes, thank you. So the implementers have been able to engage in their programs, the parents. We also have conducted activation sessions that have been supported by FHI 360 and with all partners who are working around adolescents. So in those sessions, we have brought parents. They've been engaged in dialogues, but they've also shared their own experience. We've also had opportunities through other programs that have been implemented, such as the Dreams. We have the Agape program. All these have engaged the parents to bring them on board to understand what interventions are being applied on the adolescents and why we are pushing the agenda that adolescents should access prevention interventions for themselves. And this is evidenced by the number of teenage pregnancies that we have had as a country. It is evidenced by what I've just explained. The incidence levels of HIV are still very high. The prevalence that keeps rising among the adolescents and young women. So all that is what we have been doing. And we have created dialogue groups also in the communities where parents can be talked to. Also through the church, targeting the church leaders, training them on what we have, and then allowing them to go and use this information with the church congregations that they are leading or the spaces of faith that they have. So these are some of the interventions, the approaches or the efforts that we have used to reach the influencers so that they can be able to influence the adolescents and young people to access services. But we've also gone further through policy formulation to ensure that whatever we are doing, we are leaving no one behind. We make sure that as we target the young people, we also ensure that the adults are also brought on board to understand. The other method we have used to approach, especially for parents, it's also to make sure that there's male involvement. Most of the time, interventions have involved female parents or female, but we want the males also to be engaged, not just as their partners, but also as people who hold authority and influence over the adolescents and young people. Thank you.
Great. Thank you for that. So dialogue, sensitizations, policy formulation, and also male engagement, not just as partners, but also as influencers. Very powerful. Thank you. Polo, over to you.
Oh, thank you very much. So what we have done is similar like what Ellen has said, but maybe to add that what we saw helping for is having public participation meetings, what we called public gatherings, going to the community, grouping them maybe as mothers and fathers or together at times to kind of talk with them on their own to understand and hear what they want to hear and how they think they can help the young people. This is done through our chiefs as our authorities, as our religious leaders and so on. But we have also recently done what we call human-centered design sessions, where we bring these young people from the community selected by our providers at times, our mobilizers, or even our leaders in the community. We bring them together, they sit down in a one-day session where they now talk to each other. We open a platform for dialogue. Young people will sit on their own and talk and what are the challenges and how they want their parents to support them. And then the parents would do the same as well. And then they come together to share their feelings. This has helped a lot because it kind of gets them to be free, because it's not a session where maybe, which is difficult with most parents, where a young person is sitting one-on-one in a house maybe together. It kind of opens opens up and a parent hears how other young people feel, and then they go back and we follow them to see if anything has changed in communication, if they can also support each other. And we've also done the live radio programs that normally last for 30 minutes. And then it's a live radio program where young people talk up with their parents and say, this is what I want, this is what I need. And then depending on topics, parents also would come and maybe share their testimonies and say, I have started talking to my child, I have started supporting my child, so this is what is happening. Maybe last year to say that we also use social media a lot, where we have on our Facebook pages, we have videos of these testimonies of parents and of young people and posters that support our initiatives generally. Thank you very much.
Great, thank you for sharing that. So again, having forums with mothers separately, fathers separately, and sometimes bringing them together, a HCD approach to intergenerational dialogue, and also radio programs. To our last question, what would you say are the facilitators or barriers to PrEP support that would be most critical to address that have been most critical to address in your activities? So when you are having these dialogues and discussing PrEP use, what do you think have been the main facilitators or barriers that you have had to address within your activities? Ellen, do you want to go first?
Yeah, sure, I can go first, yeah. So in terms of, I'll start with barriers. What have been the barriers? From our perspective and the experience that we have had, critical barriers have been stigma. Stigma has been something that has been a big barrier because of the fact that PrEP, oral PrEP, we are taking the ARVs. And most young people, when they go to the facility, they're enrolled on PrEP, and then they get home. There's this stigma that goes on because those who see them taking the drug, they think, oh, so you're also HIV positive. And still stigma is very high here. That causes PrEP use to become difficult. But also the fact that the pill burden, you are okay. So when you're taking the medication, others start, but because as they go along, you know, they have this sense of saying, oh, but I'm just okay. And that becomes also a barrier to PrEP use. The other is also lack of proper information. This has also contributed to as a barrier for PrEP use. Most information is scanty. Me and you who are found in forums, who understand, we know what PrEP has been able to do. But out there, the target populations, they haven't received adequate information on the effectiveness of PrEP, the efficacy of PrEP. So that also becomes a barrier. They will take it, but they doubt, will this really work? Will this contribute significantly to preventing me from having HIV? But also their behaviors. When you're targeting, depending on the population that we are targeting, if the risk is low, you find that the risk perception is, they won't be so much eager to take the drug, because sometimes when they look at their sexual engagements they are not so active, and therefore they will take it for some time, stop, start again. So that also is a barrier. In terms of what facilitates the use of PrEP, of course, when you have the desire to remain negative, that is a great facilitator, to remain negative, and also to ensure that you influence others. You have a passion to protect yourself, and you have a passion to remain negative, and also that you know that because of your lifestyle, you want to protect yourself from acquiring the HIV. Thank you.
Thank you, Ellen. Polo?
So One of the biggest barriers, I think it's been said a lot, is about taboo. Talking to parents, talking to the young people is not very easy for many because they have not learned or been given an opportunity to understand how they should do that. So it's a very big problem where now opening discussions is sometimes challenging, but soon helps. But also looking at I think, as Ellen said earlier, most mothers, what we have seen is they have information, they go to facilities, they understand better maybe. But when you look at in most of our families, fathers are the ones that make decisions all the time, and everybody has to respect and they give guidance. But you find that most fathers are not really included. What I've seen even in this human-centered design sessions, you find that fathers are very reluctant to come, but the decision still it's made by them. So that's another thing of kind of talking to the parents, especially the mothers, to say, let's also include the fathers in this discussion as you go on. That's another thing. And another one is understanding, like I said, the gap between the age and the era that young people are living in is really a big problem to really understand. It's like having this HIV prevention methods, it's kind of promoting promiscuity or behaviors that mothers do not really tolerate. So it's now us talking about why it is important for young people to have those prevention methods. But facilitators, when we sit with these parents, we've seen that sharing statistics, talking about testimonies, maybe even having young people talking for themselves where possible, it really has helped us a lot. And maybe to not repeat what Ellen has said, but that's in general what we have seen in working and what the barriers are now. Thank you.
Amazing. Thank you very much. So stigma continues to be a major barrier. Some of the other barriers you've mentioned are taboos around discussing matters of sex, especially between parents and young people. Pill burden has also been mentioned. So highlighting some of the facilitators that have come up is when individuals understand risk, then it is much easier to pass this communication and also engage. Providing the evidence for the infections and also personal stories of young people. Great, thank you very much. This has been such a great session. We have gotten a lot of positive comments about how informative this has been. Thank you very much for joining us. And we've put a number of links to the resources that are available for providers and for many others that you have asked. We will be able to share more information to all those who've registered and shared their email addresses. Have a lovely evening or morning from wherever you joined us from. So we have our quarterly webinars taking place through the MOSAIC Global PrEP Learning. So watch out for that. The next session is in March, and circulate this as much as possible once we send out the link for registration. Thank you. Have a lovely day.